So I guess it's too early for the live case. Will somebody let us know? Or I suppose we go with the next presentation then. Well, thank you very much.
Thank you.
They're ready.
They are ready? Well, can you confirm that?
Do you hear us?
Yes, yes.
Yes, we can
Okay.
hear.
We can explain you what is our progress up to that moment. And probably,
Thank you.
Professor Stankov, is somebody ready to present the case? Excellent. Where is Dr. Vasiliev now? Убедете се на доктор Василев веднага да дойде да представи случая. Okay, so it's a patient operated long time ago, years ago, for type A dissection with quite a big aneurysm of the false lumen, still persisting after the operation, and unfortunately enlarging during the time. In probably several minutes, you are going to take a look at the pictures of the CTA, and you are going to advise us what to do. In fact, I will update that we are aiming to implant a stent graft into the aortic arch with landing zone into the surgical. Go ahead. Within the surgical graft implanted years ago over the coronary arteries in the ascending aorta. And probably one of the most specific part of the procedure is the protection, the preservation of the flow into the brachiocephalic vessels. So we are going to make a connection between a big femoral sheath and left carotid and the right axillar artery in order to have a retrograde backflow from the femoral to the brain vessels. We are going to use this maneuver in order to provide brain perfusion during the in situ fenestration. This is the second accent. The second accent of our procedure will be in situ fenestration of the aortic stent graft implanted in the arch. Are we ready with the PowerPoint? Let's upload the PowerPoint, and we are going to explain you more. It's probably we have, in fact, Professor Stankov in the meantime have done several very important steps. So okay, so we are going to show you the progress up to now. So we are starting from the first angio. Okay.
Yes, we are.
This is the injection of contrast into the axillar artery. It's provided by the right radial approach. So the right radial approach is used in order to position a pigtail into the axillar artery in order to have anatomical landmark for the puncture of the axillar artery. Okay, you see this is the puncture and also the wire crossing by the axillar artery. Okay.
Ivo, sorry to interrupt. If
Yes.
you can ask the person that is uploading the PowerPoint to close the file explorer. Yeah, great,
Okay.
because it was on the
Good.
screen.
Let's wait 3 seconds up to the PowerPoint it's uploaded in order to have more detailed explanation of the case by Dr. Vasiliev. And okay, so we are going to have six vascular accesses, both radial arteries, both axillar arteries, and retrograde left carotid puncture. In fact, the retrograde left carotid puncture is already done, and both axillary arteries are
both
only the left. Okay.
Left brachial.
Okay, excellent. Very good. So, yeah, it's Professor Stankov is right that from the left side for the subclavian in situ fenestration, we can, excellent, position a right ventricle electrode for rapid pacing,
It's ready.
providing implantation during the implantation of the aortic graft. And we can continue now with the explanation of the vascular accesses. Okay. Next, this is the femoral approach.
Both femoral, yes.
Both femoral. In fact, one of the femoral approaches is for the aortic graft implantation. The other femoral approach is for providing the retrograde flow from the femoral to the carotid arteries. Next. Next. Nothing special. So this is very important.
Very important, yes.
This is very important. Position of a wire inside the carotid artery, left one, in order to have a very good landmark for a retrograde puncture of the left carotid artery. Next. Next. So we have conscious sedation of relatively deep conscious sedation of the patient, but not intubation. We are ready. In fact, our colleagues from anesthesiology department are ready to make intubation if necessary, but our general approach is not to intubate the patients. And more or less, this is the progress up to now. And we have to position two large sheets in the femoral arteries. One of the large sheets will be utilized for splitting the flow into the left carotid and into the right axillary artery to provide the perfusion.
Okay, let's go.
Okay, let's go ahead. Some comment or some questions? Are you ready for the presentation? Okay, our colleagues are ready for the PowerPoint presentation, and we are going to share. Yes, I see you see already the screen.
Go.
Okay.
Трябва 30.
Okay, go ahead. You can present the case. Dr. Vasiliev will present the case now. To be everything well structured. Слушалки за него, за да го чуват. Okay.
Okay.
Go ahead.
Hello to everyone. The case is about an in situ fenestration of the aortic arch, as Lieutenant Stankov and Professor Petrov already said. The patient is a 53-year-old male patient who 4 months prior to this admission had an open surgery for implantation of an integrated open 34 because of aortic dissection type A Stanford. So the patient has already underwent an open heart surgery. So after that, on a control CT scan, there is observation of a kink with an aneurysm dilatation up to 60 millimeters, and dissection of the woman with entry immediately after the kink. Also, there is a flap going to the left common carotid artery, to the left subclavian artery. So basically a case of hybrid approach treatment of the patient with type A Stanford dissection, treated firstly with an open heart surgery, and after that, because of extreme kink with aneurysm dilatation, directly after the implanted intergut oven, we are going to do an endovascular only treatment with in situ fenestration, because the patient is deemed at high operative risk, and another cardiac surgery for him will be very high risk for his life, and that is why endovascular technique is adopted. Basically, the in situ fenestration can be performed with laser, with leader, and electrocautery connected wire or radio frequency ablation wire. Also, something I didn't mention earlier is that when our colleagues did the operation, the first operation, they had
Da vidim
to
udače gore.
re-operate the patient because they had
Yeah.
to reposition the integrator prosthesis. So if we let them operate again, it will be third operation for the patient in 4 months.
Още един път водачи.
So basically, I already told you about the CT scan of the patient. Here is a picture of the echo of the patient, where you can see the aneurysm dilatation of the aortic arch, and also the intimal flap of the arcus of the aorta, showing exactly the place where Professor Petrov and Zen Stankov will work in a couple of weeks.
Did you show the CT?
We don't have the exact pictures of the CT, Professor Petrov, but I already tell them everything from the CT scan. Here is the text.
So you have to believe us.
Yes.
Okay, we are going to make orthography in order for you to see what is the anatomy.
Now we are in the aneurysm, we see.
Okay, this is the crossing of the arch.
Change the wire with the stiff one because we see the trunk.
There is one of the tricks that we are going to utilize. Dr. Vasiliev mentioned already that there is extreme tortuosity, and in order to overcome this extreme tortuosity, we are going to...
Ivo, sorry,
Yes.
can you ask the camera operator to show the screen so we can actually see what, because
Okay.
the camera is
Указвате
pointed
ни
on
нас,
you.
това вече не ни интересува.
Scalpel.
Yeah, perfect.
Okay, водачи.
Okay.
And now we see the screen.
10 French.
Okay, so you have a
Okay.
pigtail in the ascending aorta, and you are with the stiff guide wire also from the right side.
Exactly.
in the arch.
Yes, in order to position the guiding catheter that we are going to utilize for the in situ fenestration, we have put an extremely stiff wire. This is the Lunderquist wire, and I will try to make initial angio in order everybody of us to see what is the situation. Let it be 20 by 10. Other. Okay, increasing slightly the volume of injection. Увеличи веднъж. Okay, more or less it's not bad. So this will be the first injection, orthography. Okay. Probably you can see the aneurysm just in the middle of the arch, quite big. And we are proceeding with the
10 French.
next steps. We are positioning 10 French into the axillary artery. Why 10? In order to have enough space, both over the stiff wire, as we mentioned already.
Okay.
Excellent. The sheet is already on site. You probably can see the tip of the sheet. It's probably just at the bifurcation of the subclavian and the carotid artery. So I was explaining why 10. The 10 French sheet is utilized in order to both fenestrate, so to accommodate the catheter for fenestration, and to provide flow, retrograde flow into the brachiocephalic trunk, in order to provide brain perfusion during the in situ fenestration. So we are positioning now the wire through the retrogradely punctured retrograde puncture.
X-ray.
Okay, you see the retrograde sheet and the wire that is already, the wire is already into the ascending aorta, and even more, it's went back to the brachiocephalic trunk on the deep loop shape.
For more support for the
For better support for the. Okay, we are positioning now the 8th French sheet by the retrograde left carotid. We are going to slowly, 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 slowly.
that's it.
Искам малко по-дълбока седация. Okay, so we have the two sheets for the in situ fenestration already done, and now we are going to connect with a large tubing. Large tubing. We are going to connect the
Left brachial approach with long sheet.
Yes.
45, 8 French.
Okay, we are going to put a 8 French left brachial sheet in order to provide access.
X-ray.
To provide access for the left subclavian fenestration. So we are aiming to perform 3 fenestrations: left carotid, brachiocephalic trunk to the stent graft aortic, and the left subclavian.
So
Obviously,
it's going to be a total
Yes.
Arch reconstruction, Ivo, with
Yes,
three fenestrations?
exactly. It will be like
are
surgical
you-
total arch.
At the injection, it looked like you have a kink at the distal anastomosis of the ascending aortic arch between the graft on the ascending aorta and
Probably, yes.
the arch.
Absolutely. You are right.
Yes.
And because of that, we are going to position a Lunderquist wire. That is our usual approach for the implantation of the aortic graft and under rapid pacing. Okay, now we are going to position the tubings into the right axillary artery and the left retrograde carotid.
Bypass.
So we are using a large tubing in order to provide flow for both, and as you can observe probably here there is a split. So we have to connect this to the 8 French femoral, and there is a splitting where here. There is a splitting of the flow. You see? Splitting the flow from the 8 French femoral. Okay, we are going to flush very thoroughly everything before starting the connection.
Ivo, could they
yes.
zoom in on that so we can see what it is that you have in there?
Yes. Please zoom here a little more and centralize. My arm to be seen. Excellent, very good. So, I'm explaining. This is the femoral sheet. Here is the tubing that is divided in two, and it will be flushed. Okay, this is the flushing. Okay, like that. A little more. Okay, it's flushed. Excellent. Okay, we are ready. We are ready to connect.
So
now.
actually, you will achieve bilateral selective brain perfusion,
Exactly,
like in surgery when we do
Absolutely.
reconstruction of the arch.
We have measured many times. We have measured many times the pressure that we are providing into the carotid, left carotid, and the axillary artery. And it's around 70% of the systemic. It's around 70% of the systemic. And after covering the, in fact, the carotids, we are going to show you how the flow is going from the femoral up to the brain. Okay, we are ready now to position the Lunderquist in the ascending aorta. Okay, a catheter.
Yes.
Now the wire is inside the aneurysm. I would like to have a catheter in order to go beyond the aneurysm in proximal direction in order to position the wire into the ascending aorta.
Положи, например.
С декзор ли сме? Наближава най-важният момент, искам да не мърда въобще. Грам. So, this is the loop of the Lunderquist into the over the aortic sinuses.
And you have selected the curved Lunderquists in order to
Yes.
not to damage
will-
the aortic valve.
yeah.
Yes.
Absolutely, it's pre-shaped and a little more. So we increase slightly the curve of the Lunderquist in order to be gentle and not to damage anything. Now we have positioned a large sheet before going sheetless implantation of the Valiant Captivia. So this is a 20 French sheet.
Great.
It's enough. It's a step up in the French size. Step up in the French size. Of course, it will be close by Manta. And we are preparing now. We are preparing the stent graft, aortic stent graft itself. We probably didn't check the pacemaker. Did we check the pacemaker?
Pacemaker working.
Yeah, the pace.
But we check again.
It's excellent
for the
because,
start.
yeah, excellent.
I put now catheter on the axillary for the pressure
Yes,
to see the difference between aortic and cover
yes.
carotid artery.
We are going, in a minute, you are going to see what is the pressure in the covered. A little more.
Enough
Yeah.
here.
Okay. We are going to put the second arterial line,
Rossi,
the second arterial line in the pigtail, position in the brachiocephalic. Okay.
we see
So you see the both arterial pressures. Of course, they are equal now, but in a minute, there will be a difference. This is not the right position. Okay, keep. In the meantime, we have lost the ascending aorta position. And because this is the most important part, we are going to reposition the catheter. Какъвто и да е. Не, катетър. Нека да е десният.
десен катетър, Роси.
Давай multipurpose. Okay. I'm going to use a multipurpose catheter for repositioning of the Lunderquist wire. like that. We are probably even, yeah, we are there. Because several minutes ago, the wire entered the left ventricle. And in fact, like we say, the left ventricle is the extreme version of the true lumen. So everything is starting from the left ventricle. It means we are definitely in the true lumen. Okay, super. We have already the Valiant Captivia prepared. And we are going to go sheetless through the hole that we already prepared. Wire. Push the wire a little. Pull the wire a little.
Push-pull.
This is the famous push-pull technique.
Okay, let's check the pacemaker.
Frank,
Yes.
Ivo, Frank wants to know
Yes.
what endograph do you use. It's a Medtronic Valiant, yes?
Valiant Captivia,
Yes.
large size. We are going to be prepared.
Super.
Just Usam Dese, I want to make an injection in order to be sure that we are. It's possible to go a little more.
Yes.
And with tension, Rossi, stuistam.
Little more.
A little
of the
more.
pigtail. That's
A little more. Face on. Stoi se.
So you're rapid pacing, you're in the Dacron graft, and you're deploying.
Face off. Okay. Professor Stankovic is showing me that there is almost no difference in the pressure. That is in fact
okay.
excellent.
Yeah.
Let's push pull.
The straight position for the remove.
Okay.
Okay. We are again in the left ventricle.
Yeah. You see the wire is in the left ventricle. Okay. Fantastic.
Price tension.
Okay, good. We are going to interchange with 20 French sheet. Okay. Once again, please note the pressure. You can see the almost overlapping curve of the arterial pressure in the covered brain vessels and the systemic. Okay. Okay, good. In fact, the best way, it would be to position a pigtail here.
Yes. Pigtail.
In order to liberate the other one, pigtail. We are going to position now from the big femoral approach, a pigtail, because we don't need it anymore, because
It's important for the lasso.
yeah, it's important for the lasso, you are right. But definitely before the lasso, we are going to measure very real systemic pressure, the most real, the aortic one. Released. Excellent. Okay. Now I will connect the line, the main arterial line, to this pigtail. We are already, and now this is absolutely the truth regarding the ratio of the carotid pressure and the systemic. As I mentioned, we are providing around 70% of the systemic. Could you please?
Yes, of course.
Okay, good. So we can remove this pigtail here. Stork. I will remove now the gelled pigtail. You see that the pigtail is gelled behind the stent graft, and this is also a good sign. This is good sign because, in fact, the pigtail, I cannot remove it. It means we have a good apposition of the proximal covered part over the healthy aorta. In fact, it's probably we are inside the surgical graft. So as I mentioned, we are using in such situation the surgical graft as a landing zone. Okay, and now the pigtail is inside the brachiocephalic trunk, touching the graft into the aorta. So now we are going to proceed with the fenestrations.
Listen. Borders.
We are using the so-called triple telescopic system, sheath, guiding catheter, inside the guiding catheter, microcatheter, inside the microcatheter, the penetration wire, the so-called electrified wire. Okay. And we are going to put a lasso, snare.
Yeah, yes.
We are going to put a snare waiting below the probable site of the penetration, of the fenestration. Okay. Right. 5 French or 6 French, right? Let it be 5 French Judkins right guiding cutter. And inside the 5 French, I mentioned yesterday in one of the rooms that we are using not the original cutter of the lasso, but we are using a right Judkins because it's steerable. So we can aim at different positions and different directions in order to position the lasso on the right place.
Stoi trees.
Okay, the catheter is there. We put a Y connector and we are going with the lasso inside the catheter. Okay, let's go. Okay, excellent. Okay, I will put. Good, you probably see. Now this is the lasso coming. The lasso coming. And now it's more or less in a good position. Okay, to catch the връчицата мъничката. Okay. Perfect. Now, okay, this is
I prepare the system for the
puncture.
Wire. Okay, super. Multi-tool къде е?
Do we have the stato?
Yes, this is a stato.
Okay, we have a stato, one of the most aggressive wires for peripheral intervention is the situ wire with aggressive non-hydrophilic metallic tip. The accent is in metallic, so the tip has to be metallic in order to provide. Какво има? Всичко е наред. So we are going to put a stork wire or whatever, some wire. Okay.
Приготви си типчето.
And after positioning the stork wire, okay, good. We are going to utilize the multi-purpose guiding catheter in order to aim to the tissue of the aortic graft, the surface of the aortic graft. Let me see, we have lost both.
We can put here.
Yeah. The pressure, I want to see. Excellent. Okay. Hemodynamic control. Let me see.
Малко нагоре. Окей.
There are several options. Multi-purpose or right Judkins. Probably right Judkins would be better.
Окей.
Let's change. We are going to take a right Judkins catheter. Десен Judkins ни трябва.
Водещ.
Водещ. От тук нататък.
Да.
6 сава. 6.
Не. 6 е перфектно.
We have here the right Judkins. Everything is good. Okay. More or less, something like that. Yeah,
Okay.
I feel touching.
Let's see in the right direction.
So the
Now
trick,
look.
Ivo, is to aim the middle of the graft, not to be too tangential,
Absolutely.
yes?
This is the reason we just changed the position of the panel in order to have notion in two projections. Where is the cutter? Yeah.
That's good proof. Отиди малко краниално.
I definitely have a resistance. Go left, много ляво. Много. Още. Супер. Запомня. Remember this picture. Okay. I'm pulling slightly the lasso. And we are going to be ready for the catheter. I mean the supportive catheter. It's a Trailblazer. And I will try to feel again if there is a yeah. Okay. Let's proceed with the. So we have the Trailblazer big microcatheter, and inside the Trailblazer there is a small microcatheter. The small microcatheter is a coronary one. You see probably the point of the small microcatheter coming.
So you have a Judkins-Rice trailblazer and
coronary microcatheter.
microcatheter. So two microcatheter actually.
It's a fine cross. Perumo. No. Okay. Let's change a little the position. We are playing a little with the catheter in order to. Okay. Is it good?
Microcatheter.
Yeah. It's not good. It's not bad.
Perfect.
Okay.
Now we're going to connect the catheter with the wire.
I would like to take a look. Do you see the points?
Zajedno увеличение.
Perfect. Okay. Now I will try. No. It's again a side.
Ah.
So now
It's much better.
it's probably just touch it without push. Just touch. Touch. Let me feel the point of the micro. Okay. And the wire. Okay. Ready? Go.
Yes.
This was the first attempt. The wire didn't cross.
Ivo, you had a lovely lateral view before to show us. Would you want to check that again, just as you're putting the wire to make sure the wire's going
Yes,
towards the graft?
just.
Just in case it's going in the opposite direction.
Още.
Малко трябва да отида към
It
пикстела.
looks great. I remember, Frank, a couple of years ago, we were watching Ivo do a similar case, and he was using the chimney technique. And this is so much more elegant, isn't it? It's almost simpler, if I can use that word, because it's anatomical and it's percutaneous, which is the other remarkable thing.
Покрая.
So it's like endovascular, Donald. It mimics the frozen elephant trunk technique with which can be performed with the
I
Thoraflex,
keep
which
the
is
catheter on the place.
Yeah, keeps
needs,
cut.
it's so we're using it
Now,
on a large scale.
look better. I think it is.
Go left.
I still
Тук какво натискаме? Синьото ли?
Синьото.
Значи натискаш тук. Не жълтото, а синьото. Аз ще ти кажа какво е.
You're using the
Just
sheath,
to
Eva, you're using the sheath really very much to support what you're doing, to control your ability to puncture the graft.
Дани, готова ли си? Давай.
И не трябва да е мокро.
Факт. Не трябва да се опира въобще в... Не, във въздуха не е нужно, но не трябва да се опират. Okay, we are preparing now the system. This is the microcatheter point coming. Един компрес искам. Готова ли си? Натискай. Пускай. Много е добре. Знаеш ли защо? Защото угъна на катетъра, което не че сме там и създава напрежение.
Да проверим водача да не трябва да го сменим.
Давайте друг такъв водач. Друго е статус. We are going to change the wire because there is some damage of the tip, and the tip is the most important part. If you want, you can probably continue with the program, and of course we are going to record everything, and we'll let you know when we are ready to be online, to be live.
Good
What do you think?
It's come across extremely clearly here what you're doing, and so if you want us, we can carry on and keep in touch with you.
Okay, good.